Hi, my name is Jason Gotlib, and I'm from the Stanford Cancer Institute in Stanford, California, and I'm delighted to provide you an update with um, the newest knowledge in mastocytosis. And I'd like to thank the organizers of SOHO, Saudi Arabia, for the invitation to speak to you today. These are my disclosures. Well, how about we start with the World Health Organization and International Consensus Classification diagnostic criteria for systemic mastocytosis. There are major and minor criteria. The major criteria are mast cell aggregates in the marrow or extracutaneous tissue. The minor criteria are spindle-shaped mast cells, the presence of the KIT D816V or another activating mutation, the presence by immunohistochemistry, and one can also use flow for CD25, CD2, and or CD30 on mast cells, and a serum tryptase level above 20 nanograms per mil. Now, the WHO and the ICC differ a little bit in terms of what is required to fill the criteria. The WHO requires one major and one minor criteria or three or more minor criteria, whereas the ICC, one major criteria is sufficient or three or more minor criteria. Now, I typically think of mast cell disease as not advanced versus advanced. In the non-advanced category, there is indolent systemic mastocytosis or ISM, and this is by far the most common subtype of mast cell disease. Now, in the WHO, bone marrow mastocytosis or BMM is a separate category for indolent mast cell disease and is characterized by no B findings, which I'll talk about, and no skin disease, and a tryptase level generally less than 125 and has a better prognosis than even indolent disease. There is smoldering SM or SSM, which is characterized by two or more B findings, and this is more of a transitional or intermediate state in terms of prognosis. And then there's advanced disease, and this consists of three subtypes: aggressive SM or ASM, which constitutes one or more C findings, again, which I'll talk about; systemic mastocytosis with an associated hematologic neoplasm, SMAHN, and that neoplasm is almost always myeloid in nature; and then mast leukemia, which is very uncommon, but the most aggressive. And I would say that amongst advanced SM subtypes, SMHN is by far the most common, representing 70% of all advanced SM subtypes. Now let's talk about B findings and C findings since I alluded to them. B findings reflect higher burden disease, and this reflects a bone marrow mast cell burden of 30% or higher with a tryptase level more than 200, the presence of hepatomegaly or splenomegaly or lymphadenopathy, but without the presence of liver function abnormalities. There might be signs of dysplasia or myeloproliferation, but patients don't meet frank criteria for an MDS or MPN. And added in the World Health Organization in 2022, a KIT D816V variant allele fraction greater than or equal to 10%, reflecting again higher burden disease or at least substantial multi-lineage involvement. C findings reflect the need for cytoreduction and reflect also organ damage. This, for example, includes cytopenias due to substantial bone marrow infiltration, liver function abnormalities, not infrequently with ascites or portal hypertension, and then large osteolytic or lesions or pathologic fractures, papillosplenomegaly, but with hypersplenism that has a low platelet count, and then malabsorption, which is reflected by hypoalbuminemia with weight loss due to GI mast cell infiltrates. Now, it's also important to note that I use this phrase all the time, that neoplastic mast cells are not equal opportunity organ offenders. That is, there are some patients that can have substantial bone marrow disease but little liver disease, but some that have very little involvement of the bone marrow and have a lot in liver with a large liver and increased alkaline phosphatase, for example, which is the most common presentation of liver disease. But mast cells can be, of course, in the skin, the liver and spleen, the GI tract, and the blood and bone marrow and other organs, but those are the most common. Now, again, thinking about non-advanced versus advanced SM, non-advanced SM has a normal or near normal life expectancy. The goals of such patients and their care is to reduce mediator symptoms and improve quality of life. Conventional therapies include antihistamines, leukotriene inhibitors, gastrochromochromate sodium, and ketotifen. And whether it be non-advanced or advanced disease, one is always asked to carry an EpiPen to abort potential life-threatening anaphylaxis. For advanced mast cell disease, the life expectancy is much shorter, less than 6 months, for example, in some patients with mast cell disease, to about 3 to 4 years. The goals of therapy are different there: to reverse organ damage, yes, improve quality of life, but also to extend survival. Historical therapies included interferon alpha, hydroxyurea for the associated hematologic neoplasm, various forms of chemotherapy, and also bone marrow transplantation, and also cladribine has shown activity in the disease. But now with the era of KIT inhibitors, the calculus regarding the types of therapies we use is dramatically changing. I think it's important to highlight SM with an associated hematologic neoplasm. Again, almost all the time it's myeloid in nature. And this can be, for example, an MDS, an MPN. Most commonly, it's an MDS MPN, such as chronic myelomonocytic leukemia. But you can also have an acute myeloid leukemia as well. Of interest, and importantly regarding therapy, the KIT D816V mutation can not only be in the mast cell compartment, but also in cells of the AHN, for example, monocytes in chronic myelomonocytic leukemia. I think one of the major takeaway messages of this talk is that one needs to identify the KIT D816V mutation with a high sensitivity assay. Importantly, NGS panels are not often sensitive enough to pick it up. So in that regard, using allele-specific PCR for the KIT D816V mutation or digital droplet PCR is very important, because if you do a low sensitivity assay and say that the KIT mutation not found, then one may be inclined to use imatinib because the KIT D816V mutation is imatinib resistant. But almost all the time, with few exceptions, you will find a KIT D816V mutation in advanced disease in almost all cases of lower risk disease, for example, indolent disease. Now, the mutational landscape of these diseases can change when the disease advances. So in addition to KIT, one may find, for example, in smoldering disease, the KIT mutation not only in mast cells, but in other myeloid lineages. And this is what we refer to as multi-lineage involvement. It reflects the kind of spread of the KIT mutation and the fact the disease is advancing. In patients with advanced SM, we not only have the KIT mutation, but we identify other mutations such as SRSF2, ASXL1 or RUNX1, and also gene mutations in CBL, JAK2, and EZH2. These are often linked to the associated hematologic neoplasm, but they can be found in mast cells, and this creates more genetic complexity and can make it difficult when one is considering monotherapy with KIT inhibitors, because the genetic complexity may be the basis for relapse or resistance. Now, one has now several prognostic scoring systems in particular advanced disease, which incorporate variables such as age, level of hemoglobin and platelets, and also whether one has one or more of the so-called SAR gene panel mutation, that is, poor prognostic mutations in SRSF2, ASXL1, or RUNX1. And patients, for example, using the mutation-adjusted risk score, or MARS, you can see that they are divided into low, intermediate, and high-risk disease, with survival in low-risk disease being not reached, versus patients with high-risk disease that survival is less than 2 years. And so this is used to stratify patients for whether they need treatment, but in particular whether they should be thought about as candidates for transplant, just as we would use, for example, with the DIPS plus or MIPS score for myelofibrosis. So what are the clinical issues for mast cell disease? Well, these neoplastic mast cells can lead to mediator symptoms, whether this is indolent disease or advanced disease, for example, flushing, diarrhea, brain fog, and of course, anaphylaxis. Patients can have skin lesions, which can be both cosmetically worrying, but also can be very symptomatic. There is the associated myeloid neoplasm that is, again, very common in advanced disease, and then the organ damage related to the mast cell component. Now, we do have now several KIT targeting tyrosine kinase inhibitors in 2023. First of all, I'll start with imatinib. Again, the KIT D816V is an imatinib-resistant mutation, so this was approved by the FDA in 2006 for patients with aggressive systemic mastocytosis, a form of advanced disease, whose KIT D816V mutation status is unknown or negative. This is easily less than 5% of all mast cell patients, so not a common use of imatinib in these diseases. Midostaurin, which I'll get to the data shortly, this was approved as frontline therapy for all forms of advanced disease in 2017. Avapritinib is a highly selective KIT D816V inhibitor, whereas midostaurin is less selective. It also, for example, inhibits wild-type KIT and FLT3. So avapritinib was approved by the FDA for frontline therapy for advanced disease in 2021 and by the European Medicines Agency for second-line therapy in 2022. And then we have bezuclastinib, which is also a highly selective KIT D816V inhibitor. This is in now clinical trials in the so-called APEX study for advanced disease. Now, avapritinib was also just approved about 4 months ago now for indolent disease in the so-called PIONEER trial. And there's a derivative of avapritinib called BLU-263 or elenestinib, which is being evaluated in the HARBOR trial for patients with indolent and smoldering disease. Bezuclastinib is also being trialed in indolent disease, smoldering disease in the SUMMIT trial. Now, this is the data from the global study of midostaurin in advanced SM. This was a phase 2 open label study. Again, you can see the 3 subtypes of advanced SM that were studied. Patients had to have 1 or more C findings or evidence of organ damage related to the mast cells. And the primary endpoint was improvement or normalization of 1 or more C findings in the first 6 cycles. Secondary endpoints included adverse events, overall and progression-free survival, and benefits with regarding symptoms and quality of life. You can see the dose of midostaurin was 100 milligrams twice a day in continuous cycles. 116 were accrued, but 89 were evaluable for response determination. And just starting on the left here, you can see the waterfall plots. You can see substantial decreases in bone marrow mast cell burden, in serum tryptase levels, which is the best biomarker of disease burden, and also spleen volume substantially decreased with midostaurin. You can see that the responses deepen over time. The response rate was overall 60%, with 45% of patients achieving a major response, that is improvement of 1 or more organ damage findings and at least a 50% reduction in bone marrow mast cells and tryptase level. And you can see the overall survival was some 29 months. In the upper right-hand corner, you can see a spider plot where you can see there's substantial reduction in the symptom burden going from black to green, with the exception of nausea and vomiting, which are known tolerability issues with midostaurin. And therefore, most patients who take the drug need to have pre-medications with some form of high-level antiemetic. And again, in the lower right-hand corner, you can see a nice reduction in the cutaneous mastocytosis in this particular patient, which is something that we've seen with many patients on the drug. Now, segueing to avapritinib, again, this is a more selective inhibitor of KIT D816V and more potent. You can see that in preclinical studies, the IC50, the 50% inhibitory concentration for avapritinib is 0.27 nanomolar compared to midostaurin, which is 2.9 nanomolar. So more potent, more selective, and you can see that with these kinograms with avapritinib on the left and midostaurin second to the right. Avapritinib was evaluated in the phase 1 Explorer study and the phase 2 Pathfinder study, and you can see that in both studies, the overall response rate was 75%. And you can see that in the phase 1 study that there was a dose escalation component from 30 to 400 milligrams, and ultimately there were two dose expansion phases of 200 and 300 milligrams, and ultimately 200 milligrams was a go-forward dose in the Pathfinder phase 2 study. And here are the response rates. You can see that the response rate overall was 75%, and 36% of patients achieved a complete remission or complete remission with partial hematologic recovery. Here are the responses amongst the 3 advanced subtypes, ranging from 69% mast leukemia to 100% in ASM, although this was a very small sample size in that subtype. Responses were better in patients that were midostaurin naive, but still very respectable in patients that were previously seen midostaurin, 59% versus 83%. Importantly, 30% of patients achieved a molecular remission of KIT D816V using a sensitive assay, that is digital droplet PCR, with a limit of detection of 0.17%. So this really is something that we've not seen with prior drugs and reflects a deeper remission in these patients. These are waterfall plots showing reductions in objective measures of mast cell burden. So in the upper left, you can see reduction in bone marrow mast cells. In the upper right, reduction in serum tryptase. Lower left, reductions in spleen volume. And lower right, reductions in KIT D816V variant allele frequency. I would also mention that we see a pattern in the histopathologic responses. So around months 3 to 7, you can see that the patient's bone marrows become hypocellular, and you start seeing some reversion of the spindle shape to more round shape. And then with further amount of time, that is month 7 to 11, you see that the mast cells tend to become more rounded and also loss of the neoplastic mast cell marker CD25. So you have loss of CD25 on the surface of mast cells within the bone marrow. And during this time, you see a very nice reduction in the serum tryptase level drawn from the peripheral blood. Now, this is just an example of a patient from my colleague, Dr. Dipti Reddy from the United Kingdom. This is a 45-year-old woman with an SMAHN, where the AHN is an MDS-MPN unclassifiable. And on the upper left, you can see the reduction in bone marrow mast cells and also serum tryptase level. On the right, you can see a substantial decrease in the KIT D816 variant allele frequency. And over time, you can see the reduction in skin lesions as well. Now, all these findings of tryptase levels and bone marrow mast cells going down, skin lesions improving are very important, but also important is how patients' symptoms are doing. And you can see here using a validated instrument, the Advanced Systemic Mastocytosis Symptom Assessment Form, you can see substantial reduction in symptoms, for example, over 11 cycles, and on the right, reductions in individual symptom scores, including, for example, fatigue, abdominal pain, skin spots, itching, flushing, and nausea and diarrhea, for example. Now, with regard to the adverse event profile of avapritinib, I would say that the most common issues that distinguish the drug are edema, that would be periorbital edema and also whole body edema. You can see that grade 3 or higher, it's about 5% of patients, but it's still a very common event. Some patients experience cognitive issues, for example, issues with attention or memory recall. This is typically low grade and quite manageable. And you can see that about 15 to 30% of patients do have myelosuppression of grade 3 or higher. So that is something that one needs to keep an eye on, but it's really a class effect, not just particular to avapritinib. I would say that the most important issue with the drug was the identification of intracranial bleeds in the phase 1 EXPLORER study. Because of this, the FDA mandated that subsequently patients who were enrolled in the study have to have a platelet count of greater than 50,000, because lower than that, there seemed to be an association with low platelet count and bleeding. With that change and with dose holds or modifications, should platelets go below 50,000 and or with platelet transfusions, the frequency of head bleeds with avapritinib in the phase 2 study was substantially reduced. You can see between 1.5% to 3%. And the current label does require that patients who be treated with avapritinib have a platelet count above 50,000. Now, there are patients that progress on avapritinib. Typically, it's the AHN component, but it can be the mast cell component. But when one has done a molecular analysis, as shown here, presented by Michael Deininger and Ash in the 2021 meeting, there was no specific pattern of which mutations occurred in such patients that did progress versus those who did not progress. Sometimes it can be a higher variant allele frequency of the KIT mutation. Sometimes it could be acquisition of a new myeloid mutation or increase in the mutational burden of a myeloid gene mutation beside KIT at baseline over the course of treatment. But again, no specific pattern. So this is an unmet need that we need to sort out why patients are progressing in terms of genomic explanations. Now, the question comes up is whether avapritinib is modifying the disease natural history. Of course, there's not going to be a randomized study between best available therapy or avapritinib. In the absence of that, this is a real-world study with data obtained from several academic centers with expertise in mast cell disease. The best available therapy include patients with midostaurin, which comprise 50% of the best available therapy arm. You can see here that regarding overall survival, that there was about a 50% improvement in survival with avapritinib compared to best available therapy. The median survival with avapritinib was some 49 months versus 27 months with best available therapy. Also, there was a 60% better reduction in serum tryptase levels in the whole cohort with avapritinib versus best available therapy. So again, this is not definitive proof, but this is very suggestive that there is some disease modification with avapritinib versus conventional therapies, including midostaurin. I would just make mention of APEX, which is that phase 2 study of the highly selective KIT inhibitor bezuclastinib. There's going to be a dose optimization phase and then a dose expansion phase. This is ongoing. The potential attraction of this agent is that there seems to be less CNS penetration compared to avapritinib. So we'll have to see whether head bleeds or other cognitive issues are an effect of this drug in patients with advanced mast cell disease. This drug is also being looked at again in the SUMMIT trial for patients with indolent disease. So what are the observations from KIT targeting trials? I would say that we are seeing partial or complete normalization of bone marrow mast cell burden, serum tryptase levels, splenomegaly, organ damage, symptoms, and mast cell disease in the skin. Molecular remission of KIT D816V is feasible and really is a new response benchmark for advanced disease. The response of the SM and H components can be highly variable in the same patient and between patients, and progression to HN remains a major unmet challenge. And so in that regard, there are now protocols starting that is looking at the combination, for example, of avapritinib or bezuclastinib with an AHN-directed therapy, such as a hypomethylation agent for an associated MDS or MDS-MPN. With midostaurin, the major adverse effects or challenges clinically are GI side effects, and for avapritinib, edema, and the issue of intracranial bleeds, which seem to be mitigated nicely with the strategies used for mitigation. So I'm going to segue just to the issue about transplant. There was one series by Sela Houston published in the JCO in 2014 that looked at transplant, but this is really from the pre-KIT inhibitor era. You can see that on the left, the overall survival was some 57% at 3 years, best for SMHN, worst for MCL, mast leukemia, and that the adverse risk factors for overall survival included the diagnosis of mast leukemia and also the use of reduced intensity conditioning versus a full myoablative transplant. And I'll get back to the issue of transplant because the question, of course, arises, what is the role of transplant in the KIT inhibitor era? I would just want to briefly talk about indolent disease. I think all of us are familiar with the fact that for indolent disease, it's focused on symptom mitigation. We try to have patients avoid known triggers, and otherwise we use antihistamines, leukotriene inhibitors. For bone disease, bisphosphonates, we will use omalizumab, an anti-IgE antibody for recurrent anaphylaxis, venom immunotherapy for patients that have a Hymenoptera allergy, and of course, clinical trials. These are patients that if they're going for surgery or undergoing pregnancy delivery, you need to engage one's collaborators, including anesthesiologists, to make sure that we mitigate any issues of anaphylaxis or mast cell activation flares in the context of pregnancy or surgeries. Now, PIONEER was a study using avapritinib for patients with indolent disease that had moderate to severe symptoms, despite being on at least 2 best supportive care medications. These are patients that were randomized 2-to-1 to avapritinib or placebo. The primary endpoint was mean change in TSS or total symptom score at 24 weeks. And there was a rollover phase, part 3, where patients ultimately can continue on avapritinib. And you can see here that there was substantial benefit in the primary endpoint with avapritinib versus placebo in the mean change in the total symptom score. And also, avapritinib achieved or met all key secondary endpoints, including reduction in serum tryptase, the KIT variant allele frequency, 50% or 30% or greater reductions in TSS, and also reduction in bone marrow mast cells. The drugs was very well tolerated. Again, I think there was a little bit higher rates of edema compared to placebo. Now shown here was a slight increase in alkaline phosphatase in some patients, though it's not clinically concerning. But based on these data, which were published in the NEJM Evidence in June, avapritinib was approved for indolent mast cell disease by the FDA, also in June 2023. So just some future directions and questions. I talked about the issue of whether avapritinib modifies disease natural history. It is quite possible. And one question is whether the depth of KIT molecular response will somehow influence this disease natural history. I don't think that's a question that we really know at this point. And maybe we should start having the conversation about analyzing MRD in patients with advanced mast cell disease with drugs like avapritinib. For SMHN, we're now at a point where we're starting to talk about how do we use a KIT inhibitor with an AHN-directed therapy. Do you treat the SM component first or the AHN component first? How do you combine such therapies? Now, in this KIT inhibitor era, how do we use these agents before and after transplant? Do we try to use a KIT inhibitor to cytoreduce patients before transplant? Do we use it after transplant to try to mitigate the chance of relapse? These are answers that are not yet answered. It may take some time. Resistance is a persistent problem, particularly in the AHN component. And in this regard, this is where biologic investigations using single-cell DNA and RNA sequencing to investigate the clonal architecture of these patients at baseline and under the pressure of KIT inhibition, I think could be very interesting to sort that out and really can inform how we treat such patients. And then in indolent disease, we are seeing improvement of symptoms and mast cell burden, but what is the optimal dosing of avapritinib in such patients? What are the safety implications of the prolonged therapy? Patients have really only been treated for about 2 to 3 to 4 years, so we need more long-term data to see if there's any toxicities that do take longer to reveal themselves. As of now, we have not seen any new concerns. So with that, I'd like to acknowledge my Stanford group and many of the mast cell investigators and patients and their families have been partaking in these trials. And with that, thank you very much. I'd be very happy to take any questions.